Sorry, guys. Okay. So as we are talking, as we are, as we said in the last lecture about breathing in high altitude, someone that is taking breath at high altitude, the FiO2, which is the fraction of inspired oxygen within the air, is constant. So you're always taking 21% of oxygen, regardless of the level where you are. But the barometric pressure reduces. So the higher you go, the lower the barometric pressure. And barometric pressure is what is even helping you drive in those gases into the airway. So if it's low, that means that there's less chance of those gases finding their way into the airway. So at the end of the day, if the PB is low, you guys remember the formula that connects PB to PiO2. If you guys remember, there's a formula that says PiO2 equals FiO2 times PB minus PH2O. So if there's a drop in the PB, the PiO2 drops, and at the end of the day, the PaO2 also drops. In response to the drop in the PaO2 or hypoxemia, there will be increased ventilation so that you can take in more oxygen. And in the process, you are going to take out more CO2, so the level of PCO2 in the arterial blood reduces, causing respiratory alkalosis. So that drop in the PCO2 and the hyperventilation brings about what we call altitude sickness that causes headache, nausea, fatigue, like because they are hyperventilating. So they have sleep disturbance, lightheadedness, fatigue, they are nauseated, and they have headaches. So that is in response to the hyperventilation that they experience at the high altitude. So there's a chronic increase in respiration, in ventilation, like you can see here. So what are the metabolic response to that condition? What are the metabolic response to the condition? Number one, the major thing that we have to appreciate here is in high altitude there is hypoxemia. That is, there's a drop in the PaO2, the small a. Due to that, you are going to stimulate the interstitial cells of the peritubular capillaries of the kidney that releases erythropoietin. So the level of erythropoietin is going to come up because of the hypoxic situation. So that is going to increase production of red blood cell that brings about increase in the hematocrit and the hemoglobin concentration. This is also due to the chronic hypoxia that you have explained. What happens to the level of 2,3 BPG? It also increases metabolism. So because of that low oxygen, you are going to have more of the the glycolytic pathway being activated. And we remember that one of the major breakdown products of glycolysis is 2,3 BPG, 2,3 biphosphoglycerol. And we remember what this does to the hemoglobin concentration curve. We said 2,3 BPG has high affinity for the beta globin chain. So because of that, it binds to the beta globin chain and stimulates release of oxygen. So it's going to cause a rightward shift of the oxygen hemoglobin dissociation curve. What happens at cellular level? There's going to be increased production of the mitochondria because the body will see that hypoxic situation as, is it that we don't have enough mitochondria to generate energy in form of ATP? They will try to produce more mitochondria so that they can utilize the little oxygen that is available. At the end of the day, it's not going to really help that situation unless the person leaves that high altitude. You guys remember that oxygen is utilized in the mitochondrion for oxidative phosphorylation, which is the most abundant way of generating ATP, not the glycolytic pathway. So because of the fact that oxygen is low, so the body will try to upregulate the mitochondrion level so that they can increase ATP production. So what is the metabolic response to all these changes? The end result is respiratory alkalosis. The level of PaCO2 is going to drop. So how will the body respond to this metabolic alkalosis? There's an alkalosis. We can see that as maybe accumulation of bicarbonate. So what will the body do? The body is going to excrete bicarbonate, which is an alkalotic agent, so that you can reduce this alkalosis. You guys know that when there is respiratory problem, the metabolic component in the kidneys compensate for that. So in response to
Yeah.
alkalosis, yeah, Dr. Luatobi. So what I just want us to pick here is that response is not immediate, Dr. Luatobi. I know that's the reason why you are saying here, because we solved the question about it when we were talking about pulmonary embolism. You remember when we were solving?
Yes, yes.
Yes,
Because you said it's not like immediate. It takes a while before that kicks in.
exactly.
The renal compensation for the alkalosis.
Yes, it takes a while. It's not immediate. So the renal compensation kicks in and they want to excrete bicarbonate. So there's reduced absorption of bicarbonate at the PCT to compensate for that. But you can augment that process by giving acetazolamide. So that's one of the major indications for use of acetazolamide. You want to reduce conversion of CO2 and water to bicarbonate. Because if you increase conversion of CO2 and water to bicarbonate, you are going to have more bicarbonate to be reabsorbed. Why not halt that process? Don't convert CO2 to bicarbonate so that you don't have any bicarbonate to absorb, so that you can waste away all the bicarbonate that are supposed to reabsorb. So that is the indication for use of acetazolamide. You don't have any bicarbonate generated. There's no bicarbonate to be reabsorbed to further worsen that respiratory alkalosis. So at the end of the day, you are treating that respiratory alkalosis. You guys remember that another indication for acetazolamide is someone that has. Do you remember? Do you guys remember any other one in neuro?
Glaucoma.
Okay, glaucoma. Yes, yes. Because bicarbonate is also one of the key ingredients in the production of intraocular fluid. Yeah. So
Yeah. Neuro.
yeah, so you can use it to treat pseudotumor cerebri before you want to do your spinal
Okay,
tap.
yeah, 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 yeah. Okay,
You can
okay.
you can use medical treatment with acetazolamide. Then what is the implication of this on the lungs? You guys remember we've talked about it. Lung is the only organ that responds to hypoxia with vasoconstriction. So, and of course, in high altitude, it's going to be chronic. So, at the end of the day, they are going to develop chronic hypoxic pulmonary vasoconstriction. So, there's going to be an increase in the pulmonary vascular resistance. So that means that there's an increased afterload on the right side. The right side of the heart is going to respond to that by undergoing right ventricular hypertrophy. At the end of the day, this person can develop pulmonary hypertension, right ventricular hypertrophy, even right ventricular failure because of this hypoxic situation. So hypoxia is happening, there's vasoconstriction. That vasoconstriction is constricting the pulmonary vessels. The pulmonary vascular resistance increases. There's pulmonary hypertension. The right ventricular side muscles wants to undergo hypertrophy to overcome that afterload. At the end of the day, they can fail and to lead to right ventricular failure. Okay, which will be similar to cor pulmonale, what we call cor pulmonale. So what is the response, of the pulmonary system to exercise? Very simple. There's a question on this that Dr. Zulia had posted. So she posted a question about this. If we had done this, you guys will be able to answer it. The clinchers, or what I just want you guys to pay attention to here, number one, is that in the venous side, there's an increase, there's a decrease. In the venous side, because you are exercising, there's high metabolic activity, the level of CO2 in the venous blood. Look at what they wrote, PVCO2, PVCO2. So that means that the concentration of CO2 in the venous blood rises. It's a metabolic waste product. You are breaking down your glucose. You are generating CO2 and water. At the end of the day, you are using oxygen to drive that combustive process. The level of oxygen drops. So the PVO2 reduces, the PVCO2 increases. That's what you expect in exercise. So because of this increase in the PVO2 in the venous blood, you guys remember chalk, Dr. Oluwatobi. I know chalk is not strange to you. Calcium, hydrogen, adenosine, lactate,
Adenosine,
potassium.
lactate, and
Yeah.
potassium.
So the CO2 is generating the hydrogen. CO2 means like accumulation of proton. Because if your CO2 combines with water, you are going to want bicarbonate and H plus at the end. So the high acidic content and CO2, it's more like a vasodilator because of the acidity that is associated with it. So there's vasodilation of the vessels, to increase blood flow to different part of the body, including the lungs. So there's an increased pulmonary blood flow because of that, accumulation of CO2. So the blood flow is going to increase the ventilation perfusion ratio, because you guys know that at the base, that's where you have maximal perfusion. So because of this exercise response and accumulation of CO2, the perfusion increases entirely across all the lungs. So it increases from down to middle to up. So it's like uniform. So that will, maintain this VQ. Because if you look at the apex of the lung, the, the the drop in the ventilation rate at the apex is not as high as that of the base. The ventilation rate at the apex of the lung is not as low as that of the base, even though it's low, but it's not as low as the drop in the perfusion at the base of the the lung. What I'm trying to say is at the base of the lung and at the apex, there's both drop in the ventilation and there's both drop in the perfusion. But the drop in the perfusion is more at the base than at the apex. It's very, very high. That drop is too much at the base. But ventilation is just minimal, just like a minimal drop at the base, at the apex compared to the base. So that means that if you want to achieve equilibrium, just try to increase blood flow. You can increase ventilation rate too, but blood flow is the predominant one because blood flow decreases massively as you are coming from up to down. So if someone exercises, it makes the blood flow increase um, um, maximal in all the regions, both in the apex, the middle, and the base of the lungs. So that blood flow is making you perfuse the pulmonary capillaries so that you can bring in deoxygenated blood or blood that is rich in CO2 from the venous compartment to the pulmonary capillary so that they can be exchanged, within the alveoli. What do you need to drive that exchange? You need to increase your ventilation rate. Increase ventilation rate so that you can take in more oxygen from the alveoli into the blood and take out more CO2 from that blood into the alveoli. So those are the two changes that are very, very important in exercise. You are increasing the heart rate, increasing stroke volume. Okay, that is also one of them. If you're exercising, there's an increase in heart rate with exercise due to sympathetic impulse that helps to increase the heart rate, increase stroke volume. That will also contribute to the pulmonary blood flow. The local vasodilatory mechanism of CO2 also helps to increase the pulmonary blood flow, like you guys can see here. So respiratory rate to meet oxygen demand and remove excess CO2 to increase pulmonary blood flow. So those two things help to increase pulmonary blood flow. The vasodilatory mechanism from CO2 and also your increase in the heart rate and the stroke volume. They increase pulmonary blood flow. And at the end of the day, you have to also increase respiratory rate so that you can take out more CO2 into the alveoli that is accumulating in the venous blood and taking oxygen from the alveoli into the pulmonary capillary so that the blood that is going to the pulmonary arteries will be rich in oxygen and it will be low in carbon dioxide. That is, that carbon dioxide would have equilibrated with the normal carbon dioxide level in the alveoli. So it should have been 40-40. And oxygen would have been around 100 or 90 millimeter of mercury, which is very similar to what you have in the alveoli. So at the end of the day, yes, yes.
Thank you for the explanation, but I did not really get how that CO2 is causing the vasodilation at the lungs. I did not really get, maybe you just have to say it one more time. Sorry, please.
Okay. So, one of the things that they said can cause vasodilation, that's why I mentioned chalk. Calcium, hydrogen. So the hydrogen part means acid.
I thought that was like the local tissue. I thought that was like in the skeletal muscle. So I'm looking at how it's now
Yes,
in the lungs.
this is exercise. You are exercising the muscle, right? All those metabolic waste products are released where? Into the blood. Do you get? So at the end of the day, it's going to also affect, the pulmonary blood flow. Do you get? Because it's in the lungs, it's in the blood. So it's going to affect the pulmonary blood flow. Exactly. So that is it.
Okay.
So in addition to that, the sympathetic drive, with exercise also increase the heart rate and the stroke volume. Do you get it?
Yeah.
So those two mechanisms help you to increase that pulmonary blood flow. So at the end of the day, you are going to have more CO2 being taken out and more oxygen being taken in. So my point there is that at the end of the day, the level of the arterial oxygen and the level of the arterial CO2 will be normal. It will be maintained. It will not change. Despite the fact that you are accumulating a lot of CO2 in your body and you are consuming a lot of oxygen in your body, although they are being consumed and they are being accumulated within the venous circulation. It doesn't actually affect what is happening at, you know, the what's it called? The arterial circulation because of this hemostatic mechanism that we have talked about. What are these hemostatic responses? Increase in the blood flow and increase in the respiratory rate. So there's a question that Dr. Zuli had shared. If you guys can remember that question, we can go back to it so that we can understand, what is happening here. So yeah, so that's that about exercise. You guys know you don't need to, memorize everything. That's a summary of what they are trying to talk about. That's a summary of what they are trying to talk about. Okay. So methemoglobinemia is just when you have hemoglobin existing within the met form. And what is a met form? Met form means that you have oxidized hemoglobin from Fe2 plus to Fe3 plus. From Fe2 plus to Fe3 plus. So, what are the things that can make hemoglobin be oxidized from Fe2 plus to Fe3 plus? If you give the person some medication like Dapsone, if the person is on local anesthetic like benzocaine or nitrite, those three things. Dapsone, which is one of those drugs that is notorious for triggering DCSPD attack, DCSPD deficiency attack, local anesthetics, all those local anesthetics like benzocaine and nitrite, those three things, any one of them. If you give it to somebody, it can oxidize the heme ion from Fe2 plus, which is the ferrous state, to ferric state, which is Fe3 plus. So once the hemoglobin is Fe3 format, you call it met hemoglobin. And we have talked about the way it works. We said it's kind of shift the oxygen deionization curve to the left, and it reduces the affinity of hemoglobin for oxygen. So it doesn't bind to oxygen as readily as Fe2 plus, but it has high affinity for cyanide. So because of the fact that it doesn't bind readily to oxygen, the saturation rate of hemoglobin is going to drop, which can cause tissue hypoxia. But this affinity for cyanide, don't think, okay, well, this affinity for cyanide, okay, I don't want you to link it to this tissue hypoxia. This tissue hypoxia is actually due to the fact that it doesn't bind to oxygen. This affinity for cyanide is very, very important for its treatment. So we maximize this ability for it to bind to cyanide in treating it. So I will explain when we get there. So of course, we've said it that it doesn't bind readily to oxygen, the saturation drops, and the oxygen content at the end of the day will also drop. I know that we understand it to this level, why the oxygen content will drop. So the typical concentration in the body is like 1 to 2%. It doesn't go, but in some situation, when it's very, very prolonged, it can, go higher than that. And at the end of the day, because of the fact that the oxygen content is going to drop rapidly, there's going to be cyanosis. And that cyanosis will not be improved by giving supplemental oxygen. It will not. So because of the fact that your hemoglobin has already been altered, so it doesn't like oxygen again. So you have to restore it back to normal Fe2 plus. You have to restore it back to normal Fe2 plus. That's the way you can treat it. So because of the fact that, it doesn't bind to oxygen and is in this met form, the blood assumes a chocolate colored blood. So you guys have to pay attention to all these color changes. Someone that has cyanide poisoning, the blood doesn't go chocolate colored. The blood still remains bright red because we've said it that cyanide doesn't affect saturation of oxygen. It doesn't affect it. It doesn't affect partial presence of oxygen. It doesn't affect O2 content. It doesn't affect hemoglobin concentration. Cyanide
Just
just...
what?
Hello?
Hello, oh, we can hear you.
Yeah, so cyanide just... What cyanide does is just to affect utilization of oxygen at the level of the mitochondrion. That's what it does. At the end of the day, you still notice that someone that has cyanide poisoning, the blood will still be bright red. But someone that has methemoglobinemia, because of the fact that your hemoglobin component, which is your ion, has been oxidized to Fe3 plus, and it doesn't bind readily to oxygen, it becomes chocolate color. So that's the characteristic color change with methemoglobinemia. So how do you want to treat it? I've said it. You don't give oxygen. What you do is to give a reducing agent that can change it from Fe3 plus to Fe2 plus. So what are the reducing agents? Vitamin C is an antioxidant. So when you say something is an antioxidant, that means it's a reducing agent. Antioxidant is either you are favoring one or you are against another one. So if you are against oxidation, that means you are favoring reduction. So vitamin C is a reductive agent. Methylene blue is also a reducing agent that you can give someone that has methemoglobinemia. So you can get the nitrite from taking diet that is rich in nitrite. Maybe the person is taking all these smoked fish or polluted water sources. You can also get the nitrite from some use of drugs, the nitroprusside and the likes. So you guys should not forget methemoglobinemia from the word methylene blue. Then the fact that vitamin C is an antioxidant, so you can quickly remember that okay, you want to reduce this guy back to Fe2 plus so that it can work normally. So those are the two medications. We'll talk about the importance of this cyanide as we move. Yeah. So cyanide and carbon monoxide poisoning, we are trying to compare and contrast them. Both of them inhibit aerobic metabolism by interfering with the action of the complex 4 of the electron transport chain in the mitochondrion. So you call that complex 4 cytochrome C oxidase. So particularly carbon monoxide will cause hypoxia, particularly carbon monoxide, it will cause hypoxia. So although your cyanide can also cause hypoxia, yes, because your oxygen is getting to the tissues, but your tissues are not utilizing them. They are not utilizing them. So for cyanide, you cannot correct it by giving supplemental oxygen. If you even want to correct that of carbon monoxide, you have to give that oxygen. You can give supplemental oxygen, but you have to give hyperbaric oxygen that is 100% oxygen, like a gas that is 100% oxygen at a very high pressure, hyperbaric oxygen. That's what you give. If you don't do that, you are going to be metabolizing by using the anaerobic mechanism, because you can't use the aerobic mechanism. Utilization of the aerobic mechanism is when you use your mitochondria, electron transport chain in the mitochondria. When that fails, you are going to switch to the anaerobic mechanism that will bring about lactic acidosis. So cyanide poisoning, carbon monoxide poisoning are cause of lactic acidosis. So you can see them as cause of anion gap metabolic acidosis. Yeah, so let's compare and contrast them. What are the exposure that can bring about cyanide poisoning? So um, someone that is on some medications, nitroprusside can bring about production of cyanide. I don't want us to forget that, although it's not listed here. Combustion generally. So people of fire victim accident and all those things, they can be exposed to cyanide. People that are taking amygdaline, so which is a component of apricot seed, so it can also lead to production of cyanide. Or you have ingested cyanide itself, the chemical itself, maybe for suicidal attempt. So people that have taken cyanide itself for suicide, people that have been exposed to combustion products or fire or amygdaline, that's cyanide, or drugs, nitroprusside. They commonly use that drug. I don't know why they fail to mention it here. So carbon monoxide generally is just waste product of combustion. So metal exhaust, gas heater, fire victim, anything that is just burning will generate carbon monoxide. Very easy. So the presentation is not, you don't really have anything distinct in the presentation. You don't have. Majority of them, they present similarly. So your presentation might not really give it away. It might not really help you to nail that diagnosis. But it's good to know that okay, both of them can cause headache, can cause respiratory distress, dyspnea, they can cause confusion, drowsiness, and both of them can actually present similarly. And both of them will have this cherry red spot. It's common to both of them. Cherry red spot within the skin. And some will say that carbon monoxide, one of the things that can help with carbon monoxide diagnosis is that you notice that you find soot within the nares of the person, the nose. They will contain soot. So, yeah, although you can also find that in cyanide poisoning too, especially people that are exposed to maybe fire in accidents. So, the breath of an individual with cyanide poisoning will have a bitter almond odor. So, we have to pay attention to all those odors too. Garlic odor, arsenic, bitter almond odor, cyanide. Bitter almond odor, cyanide. And the blood within the retina we apply red, bright red, because it's oxygenated normally. It is not losing its oxygen. So that's why the blood within the venules in the retina will appear bright red. Yeah. Okay, we just have to know that, but that's not actually the clincher that we that is important. That's very, very important, because do you even have time to be checking retina, be analyzing the venues, to be checking for the blood there? So what happens to your lab parameters? Both of them will have a normal PaO2. That's we have explained that, because PaO2 is talking about the amount of oxygen that is dissolved in plasma. Your carbon monoxide is going to affect hemoglobin. So hemoglobin is not plasma. So the PaO2 is going to be normal in both of them. In both of them. And because of the fact that they trigger anaerobic metabolism, lactate is going to accumulate in both of them, and they will cause high anion metabolic acidosis.
Dr. Obale, hello.
Yes, Dr. Joshua.
Can you please explain again why you said the PO2 be normal in both?
Okay, so PO2 is talking about the partial pressure of oxygen in the plasma. That is the amount of soluble oxygen in the plasma. Now, someone that has carbon monoxide problem, it affects hemoglobin. That is what it does. It doesn't allow oxygen to bind to hemoglobin. It doesn't affect the plasma level. So that means the PaO2. Were you there when we were talking about the equation for oxygen solubility?
I'm following you. I don't know if I was there, but I'm following you so far.
So this is it. This is the equation. Oxygen content equals oxygen bound to hemoglobin plus oxygen solubilized in plasma. So
Okay.
there are two separate things. You can see oxygen solubilized in plasma is talking about the solubility constant times the partial pressure of oxygen in arterial blood. You can see.
Okay.
So, plasma is blood. So arterial blood just means that you are measuring that plasma from the artery. Do you get it? When you are measuring the plasma in the artery, that's why they are saying arterial blood. That's why they are calling it PaO2. But it's actually talking about the partial pressure of oxygen in the plasma in the arterial blood, because your oxygen cannot exert a partial pressure when it is bound to hemoglobin. It cannot.
Okay.
It cannot. So that is PaO2. So that means that anything that affects hemoglobin will strictly affect hemoglobin, like carbon monoxide, anemia, methemoglobinemia, they will affect hemoglobin, and they will reduce the oxygen content, because oxygen content is the sum of hemoglobin and that dissolved in plasma. The oxygen that is bound to hemoglobin and the oxygen that is bound to plasma. So because of the fact that in people with carbon monoxide poisoning, it will affect the amount of oxygen that is bound to hemoglobin. Oxygen content will reduce, but it will not affect oxygen solubilized in plasma. Do you get it? So that means that PaO2 will be normal in them, because PaO2, because oxygen solubilized in plasma equals 0.03 times PaO2, that is the solubility constant, times the partial pressure of oxygen in that plasma. Do you get it?
Oh, yeah.
So I don't think you were there when we were talking about it. So I think that's why.
Okay, thanks.
Yeah. So it's going to be normal. It's going to be normal. But you are going to have elevation of the carbon hemoglobin. You guys can see now. So that means that it's the hemoglobin component that is going to be affected, because it's going to bind with hemoglobin and cause carboxyl hemoglobin. Now, if you do a normal pulse oximetry, your your PaO2 will be normal. Because your normal your pulse oximetry cannot detect carboxyl hemoglobin. It cannot detect it. It will see it as oxygen. What can help you tell the elevation of carboxyl hemoglobin is when you do a carbon monoxide oximetry. If you use the pulse one, that one detects oxygen. That is oxyhemoglobin that one detects. So it will take it as being normal. But once you do a carboxyl oximetry, you detect level of this carboxyl. Please, you guys have to pay attention to that stuff. It's very important. Normal pulse oximetry will not detect elevated carboxyhemoglobin. It is only a carbon monoxide oximetry that detects it. And PaO2 is normal. So what do you identify on CT? So I presented a case like this when I was doing house job, and this stuff is actually real. It's not textbook stuff. Someone that has carbon monoxide poisoning, they will develop bilateral globus pallidus lesion. So there will be hyper pigmentation or hyper intensity, of those globus pallidus on MRI. Maybe because of the fact that that region is actually highly oxygen consuming. So if they are not able to get oxygen, they die, they become necrotic. So, and it's usually bilateral. So once you see someone with bilateral globus pallidus lesion, you are thinking of carbon monoxide poisoning. Carbon monoxide poisoning. This is rarely seen with cyanide. It can occur with cyanide, but it's very rare. It is majorly with carbon monoxide. So I even want you guys to delete that cyanide toxicity. Don't assume that I share with it. Once you see bilateral globus pallidus lesion on MRI like this is carbon monoxide poisoning. So the only lab thing about cyanide poisoning is just elevated lactate. PaO2 is normal. In carbon monoxide poisoning, PO2 is normal, lactate is elevated, and you can see the carboxyl hemoglobin using your CO oximetry. And if you do MRI, you are going to appreciate the bilateral globus pallidus lesion on carbon monoxide poisoning. You guys should not forget. So what's the effect on oxygen dissociation curve? Cyanide has no effect on oxygen dissociation curve. It has no effect. It doesn't touch our hemoglobin. It just inhibits oxidative phosphorylation at the mitochondria. It has no effect on oxygen dissociation curve. But what about carbon monoxide? Now, guys, so if you guys remember when we were talking about that carbon monoxide explanation, at the end of the day, I know that what actually matters is the understanding. But I feel like some authority also gave another explanation for this carbon monoxide stuff affecting the shift in the oxygen dissociation curve. And again, I'm going to add another thing today that we did not mention in the last thing about oxygen dissociation curve with respect to carbon monoxide. So what we know is fine. If that one will make us remember, we can stick with it. But there's another mechanism that I want to expose you guys to. So some authority believe that if you introduce carbon monoxide, although to me it's still kind of shaky, but let me just say it. So anyone that will feel, we will go by it. If you introduce carbon monoxide to somebody, because we've said that carbon monoxide, hemoglobin has high affinity for carbon monoxide. Hemoglobin binds to that carbon monoxide, but hemoglobin has 4 chains. So carbon monoxide will only bind to, let's say it will bind to 1. It doesn't bind to everything. Let's say like 1 or 2, but let's stick with 1. If it binds to 1, it's going to displace oxygen that is in that 1. It will chase it out. So once it chases that oxygen out, the saturation of hemoglobin is already reducing. Now the other region that are now not occupied by carbon monoxide, that conformational change from CO binding to hemoglobin will now make them have high affinity for oxygen. So they will now bind to oxygen and not make it release that oxygen readily, making it shift the curve to the left. But the fact that it has chased one oxygen away from its own side that is binding it, the saturation of hemoglobin with oxygen reduces. It's no longer 100%. So I don't know if you guys, get what I've said. So what do you guys feel about that?
I think I might need a one more time repetition, sir.
Okay. So carbon monoxide is
So,
introduced.
like you said that once it already chased one oxygen out, then it makes the saturation not 100%.
Very good.
But at the same time, changes conformational change on the other receptor site for the other oxygen, absorbing them and not allowing them to release the oxygen.
Exactly.
They are now okay.
You are now shifting the curve to the left.
To the
Does
left,
that make
yeah.
sense to you, Dr. Zulia? Do you get it now? Or should I say it? Should I say it again?
Yes, I still
Please say it
so I really
again.
got it.
Please say it
Yes,
again.
Okay. Carbon monoxide binds to hemoglobin, but hemoglobin has 4 sites. It has 4 globin chains. Each of the globin chain contains heme group that can bind to oxygen. So let's say it binds to heme 1. When it binds to that heme 1, you know that oxygen is already occupying that heme 1 before. It chased away that oxygen. You get out. At the end of the day, it means that hemoglobin is no longer 100% saturated. Do you guys get it to that level? Because it has changed out one hemoglobin.
Yeah.
Now, the other site that is now remaining, the other globin chain that contains heme, the fact that carbon monoxide binds to that heme, it will now make the other receptors have high affinity for oxygen so that they will bind to oxygen. Do you guys get it? So that when they now bind to that
So
oxygen,
one heme, the globin chain is bound to carbon monoxide.
yes.
So it will change it will cause in other
To
hemoglobins.
increase the
abi?
affinity of oxygen, hemoglobin for oxygen on the other
Other
heme.
one, and they will not release that
So
oxygen.
oh,
But I
okay,
thought
that was what you said
before.
yesterday. Now you said that it
Yeah, I said
causes
that.
a comfort. It's not the what you said yesterday was that number one, it causes if oxygen is bound to it already, its oxygen will not leave.
Okay.
But if
Yes.
oxygen is not bound to it, it will go and bind in place of that oxygen.
Yes.
Yes.
It has more
that's what
affinity for it than oxygen. Those
Yes.
I got those two from
That's the
yesterday.
part I got too. But
Actually,
because yesterday
actually,
it's like it's the CO that is
So are you
causing.
saying it's the same thing? Like the same thing can occur at the same time? Because that's what you're basically saying now.
okay. You know what, guys?
So the ones bound to it already will not release it. The ones that are yet to be bound
Will not bind.
to oxygen, they are going to bind to CO. Is that what you're saying? Like it's
No.
occurring at the same
Okay. I think
time.
I get the problem. You know what, guys? Dr. Ratobi, if you remember, the purpose
Yes.
of me saying that statement is to explain the reason why saturation is not 100% and the reason why it's shifting to the left. You know that the stuff are contraindicating, like they don't go together. If you are saying something shift the curve to the left, that means that you are saying that it has high
It's
affinity.
not releasing oxygen.
You get
It's not
now you are-
releasing. It's not releasing
Releasing
oxygen.
the oxygen
Yeah.
is holding on to the oxygen.
So I'm just actually trying to give you guys a way to understand it. But I think
Balance it.
to balance it exactly. But the best way to actually explain it is what I'm saying now. The thing is, guys, you know that this exam is not really a vival exam. You are not going to be saying anything. So
Abi.
you know, it's just for you to be able to withhold that information. Any way you can palm that information is what matters. But
Just get it into
actually,
your head. Yeah.
exactly. But
I,
actually, the
I think
best
it will
way,
be better, Sha.
the what?
I said what you just said is better now. Like,
Exactly. So
easy.
you know, this is actually the best way that most people use to explain it. If you go to other sources, you might not get quality stuff. They'll just be confusing you. They'll just be saying different things. But I think the best way
So
is look at it that
so basically, when the oxygen and CO2 is the carbon monoxide is there, it has higher affinity for carbon monoxide. So as it has the higher affinity, once the carbon monoxide is binding to it, it tells the other side that any oxygen you bind to, don't release it anymore. So it shifts it
Exactly.
to the left.
exactly.
Okay.
So
Okay, so it's just like okay.
Okay.
I think I
Okay.
get
I
it
think
now.
I get
I
so
it
think I
like
get
that.
it now.
Dr.
Yes, I
Ratobi,
think
let's now
I
take it. Let's now take it
Yes.
one by one. The fact that
Okay.
carbon monoxide has bound to oxygen, has bound to hemoglobin. What do you think
Yeah.
will happen to the saturation of hemoglobin? Can it be 100% saturated again?
No.
No, it
No,
can't.
no,
Because if you support no, it can't. It
it
can't.
can't. It can't because it has already occupied one position of hemoglobin. So that means that it cannot have maximal
Of
binding
oxygen.
of oxygen
Of
again.
oxygen.
Yeah.
But it will shift that curve to
Yeah.
the left. It will shift that
But
curve
it
to
will
Yes.
not
the
allow it
left.
to
Yes.
release oxygen again.
Left
It will not allow
doesn't
it to
let
release.
go. Left
Exactly.
doesn't let go.
Left doesn't let go because it has increased the affinity of the other side for oxygen.
Yeah.
So
Yeah.
preventing the unloading to the tear.
Yeah.
Okay.
Yeah, I
Okay,
get
that
it
makes
now.
sense.
So that means we
Exactly.
had
Thank
the same
you.
confusion, Doctor. Don't have to.
Yeah. But actually, guys, if you look at it, both of them can give you that end result of can explain the high
Yes.
affinity and the low saturation. But Let's just
Yes,
stick to
yes,
this.
yes, it can
Why I like
actually.
this one now. This one is
Yeah, I think
solid.
this one
Like
too. Yeah,
this one is better.
it's
So
more. Yeah, you can hold on to something.
once CEO has gotten it like this, he just tells others the oxygen you people have, me have
Hold
motivational.
on to
Yeah,
The
it.
oxygen that you people have, hold on to it too. Yeah,
exactly. So,
yeah,
guys, not
yeah.
that I'm trying to prolong the matter. The reason why me I don't want to adopt this one initially was that I'm
Dr.
thinking that no,
Babawale,
sorry,
what
sorry.
are
Let
you
me just
doing?
tell you what I think. I'm thinking that okay, if you see
Okay.
that CEO, because me too, I used to think like that. Like just like Dr. Zidane used to ask a question. What if so I'm just thinking that you are saying that carbon monoxide has high affinity. Why doesn't it accommodate, like accumulate in all the sites of hemoglobin? Why is it taking only one or two? That was the initial
Mhm.
confusion. But I guess that's just the way it works. It will bind to it.
No, you can do a study, but when we
No,
get there, we are going to do a study. We are going to study it. Don't worry.
Maybe one can just
no,
imagine that maybe the CEO can the size is too big for all the sites, so you can only fit into one.
yeah.
Ah,
Yeah,
So
it's small. It's
this
small, but
Dr.
my.
Olushola and
Dr.
his
Lushola's
and his and his
hypothesis.
imaginative memory.
Yeah.
I'm telling you. And
So
the thing is,
guys,
do you know that this left and right curve is Dr. Lushola's this thing that is, there's one thing that he told me one time, and that thing just stuck with me.
no, Dr. Lushola has
I'm
some
telling
he
you.
has some code. I wish he can help Dr. Adu.
I'm telling you.
Dr.
Ah,
Adu likes banking on code too. So if Dr. Olushola can help Dr. Adu, because it's been a long time I heard from Dr. Adu. So
I mean,
Yeah,
I'm
that's
not good with
true.
code. I've tried my best, but I will remember code. I'll not remember the
It
full meaning.
depends. It
Like,
depends
the
on the
thing
type
just
of
be.
code.
Depends on the type of code. It's just that Dr. Julia appreciated this one because it has to do with you demonstrating something, and you can never you can never have
Yes,
them.
demonstration. That's
Like
that.
it
Yes.
was
okay.
basically it was basically moving to the left, collecting oxygen. You when you collect the oxygen, you raise your hand up. So
Mm.
you collect the oxygen from the left, you bring your hand down, then you go to your right, you release the oxygen, you bring your hand down. So you collect from the left, you bring
Bring
your
your hand
hand
down
I'm
down
close
to
to
the
telling
your
you,
right.
mouth.
as it's even that thing, as simple as it is, that's the way I just learned it. I'm telling you, I just
Ah,
put my hand to the left, I'm collecting the oxygen, I move my
no
hand back to
wahala.
the right, I'm disinfecting the oxygen.
No wahala.
It also explains your pH too. You raise your hand up to the left, that is high pH. Then you release your hand on the right, lower pH.
Oh, Dr. Francois is here. Dr. Francois. Hope you are there.
I'm here. I'm listening. I'm listening very attentively.
Okay, that's good. So don't worry, I'm still going to go back to that solubility. Don't worry, I'll go back to it. So let me just continue. So what is the treatment for cyanide poisoning? Now, what you want to do for cyanide poisoning is to decontaminate. You guys remember that we made a statement. Methemoglobinemia has high affinity for cyanide. We are going to use it here. We are going to use that mechanism here. Now, the first thing you want to decontaminate, you want to remove anything that could, maybe the clothing that is already burned and all those things that can prevent further inhalation of all those chemicals. You want to decontaminate the person, removing the clothing, take the person away from that area. Then you want to give the person hydroxycobalamin. So if you give the person hydroxycobalamin, your cyanide is going to leave the blood and going to combine with hydroxycobalamin, substituting hydroxyl, with the cyano component. So you form cyanocobalamin. If you form cyanocobalamin, guys, what's that? What's cyanocobalamin?
Vitamin
B12.
B12.
Vitamin B12. So you can always remember that. Hydroxycobalamin is given so that you can form cyanocobalamin, which is water soluble that you can easily excrete in the urine. That's one mechanism. That is one mechanism. Another mechanism for the conversion like that is giving sodium thiosulfate. Give sodium thiosulfate. So that if you give sodium thiosulfate, your cyanide is going to be removed from your mitochondrion and is going to, bind to your thiosulfate, forming thiocyanate. It will remove this sulfate component and to replace it with the cyanide. So there will be sodium thiocyanate. That one too is water soluble. It can go out in the urine. But the last one is giving nitrite. Nitrites are oxidative or are oxidizing agents. So once you give your nitrite, you are going to oxidize your hemoglobin to methemoglobin. You guys know that when you convert Fe2 plus to Fe3 plus, you have oxidized, and you are giving an oxidizing agent, which is a nitrite. So nitrite will, get hemoglobin oxidized to methemoglobin, and we know that this methemoglobin doesn't have high affinity for oxygen, but it loves cyanide. So this methemoglobin is now going to draw that cyanide away from that mitochondrion. Then you are going to form cyanomethemoglobin. Do you guys get this? Cyanomethemoglobin.
Yes.
And it will reduce the toxicity of cyanide. So that means that cyanide will not be free to bind to the mitochondrion. It will be occupied with the methemoglobin, because methemoglobin likes mopping up cyanide from all the sources it can find it. So the three things: hydroxycobalamin, so that it can form cyanocobalamin; sodium thiosulfite, or thiosulfate rather, so that it can form sodium thiocyanate; then nitrite to oxidize our hemoglobin to methemoglobin, so that the methemoglobin can bind to the cyanide and take it out of the mitochondria. You guys look at this statement that they made: reduce its toxicity. Dr. Abisola, are you there?
Yes, I am.
Okay. You guys can see they did not say excrete. Reduce its toxicity so that it will be occupied with something. We have seen this in question, so that we must get it. So, how do you want to treat someone that has carbon monoxide poisoning? Carbon monoxide poisoning, very simple. Just give 100% oxygen. That was how a competitive inhibitor for it. So the 100% oxygen will try to compete with that carbon monoxide to chase it out of the hemoglobin type. Then, in some severe cases where the toxicity is too much, you want to give hyperbaric oxygen. You are giving 100% oxygen at a very high pressure. That's hyperbaric oxygen. High pressure, hyperbaric chamber. The pressure is too much, more than atmospheric pressure. You are like decompressed. You are like pushing that this oxygen, you must go in by force. Hyperbaric is going to chase out all the CO component there. Very important. So hyperbaric oxygen, and 100% oxygen for treatment of carbon monoxide poisoning. So you guys should not forget that CO poisoning is not hard at all. It's just oxygen. It is cyanide that we need to be thinking of, the contamination. Then hydroxycobalamin, your nitrite and your sodium thiosulfate. Now, before I move, what is the effect of carbon monoxide poisoning on the cough? So they can draw so many cough. What you will use to pick out your carbon monoxide is that you notice that the curve will shift to the left, just like we are seeing here. The one that is appearing green is our carbon monoxide poisoning. You guys can see that it's moving to the left before it plateaus. Now it doesn't peak as we have in normal hemoglobin that is 100% bound to oxygen. It doesn't peak. Why? Because the peak is talking about what is happening on the y-axis. That's what the peak is talking about. It means that as the oxygen concentration is increasing from 0 to 100 and you are going along the x-axis, it's not rising correspondingly in terms of the oxygen bound. That makes sense, because we've said it already that it will reduce affinity. It will displace oxygen away from its own side so that it can occupy it, so that carbon monoxide can occupy that hemoglobin side. So at the end of the day, you not have your hemoglobin being 100% saturated with oxygen. So that means that the oxygen bound to hemoglobin will reduce. So that is why it doesn't get to 100%. It's just talking about the saturation, like around 50%. 50%. The next one is, okay, this dotted curve is talking about something that is making it shift to like the right, and is also reducing, that peak. So maybe someone that has anemia, too, it will not shift to the left because you are not binding, you are not having anything that is displacing oxygen from the hemoglobin, but it's just that you have little hemoglobin concentration to occupy oxygen. So that means that the amount of oxygen that will be bound to, in someone that has anemia too, will be reduced. It will be reduced. So that is that about it. Yeah. So I don't think there's anything.
Okay, Dr. Babali. So with everything that we've said,
Okay.
it means that with carbon monoxide, binding of carbon monoxide to hemoglobin is reversible, right?
Yes,
Even though it has a higher affinity, it's reversible because it can be
irreversible.
overcome with given 100% oxygen hyperbaric.
Yes, it's reversible.
But
Very correct.
okay, but the binding of cyanide
Mm-hmm.
is irreversible.
No,
So that's why it's also reversible.
it's reversible by using all these things that I've talked about.
Other
Nitrate
things to displace.
it.
Okay.
Okay, yeah.
Is there anything that binds irreversibly to hemoglobin?
Irreversibly? No, I'm not aware. That means that once you get exposed to that substance, the person dies. That's what it means. That's what it means. I don't think there's anything like that. I don't think so.
Okay.
Well, that thing we use is like I mean the lifespan of it until it finishes in the blood. It doesn't.
That's 120
It
days.
doesn't detach itself.
That's
Yeah.
120 days. The person will have died before 120 days for red blood cell turnover. The person will have died. So if you look at this anemia, it's shifting to the right. So that can be explained from the hypoxia. So from the hypoxia, you have to go through the anaerobic pathway, acid accumulate, cause the stuff to shift to the right. So that's the two things I want us to appreciate here. Carbon monoxide is shifting to the left. For the anemia, it is reducing in the peak and is shifting to the right. The hemoglobin is the one in the middle. It's just attaining its normal sigmoid shape and it's getting to the peak. So once we see this, we must be able to explain anything that is happening. We must be able to explain it. The common one that they can give is this carbon monoxide. Something that shifted to the left. That's the commonest one that they ask. And we have talked about it. Fetal hemoglobin, anything that reduces 2-3 ppg. Pregnancy is the same thing as fetal hemoglobin. We talked about, what else did we talk about again? Carbon monoxide, methemoglobinemia, both of them, they bring it to the left. Okay, so we start pathology. So rhinosinusitis is what we are starting with. So rhinosinusitis is about obstruction of the sinus, sinus draining in the nasal cavity. So you normally have drainage of the sinus into the nasal cavity. So they drain into what we call the meatus of the nose. So these meatus are just below the nasal turbinate. See guys, we don't need to be dilating anatomy. Just know that the sinuses of the head, they drain, into the meatus of the nose. We have three meatus: the superior meatus, the middle meatus, and the inferior meatus. Only one thing drains into the inferior meatus. Only one thing drains into that inferior meatus. That is the nasolacrimal duct. So that is why if somebody is crying, you can see the person having rhinorrhea, having discharge from the nose. It's because as the person is crying, you're having drainage of the high, lacrimal gland from the nasolacrimal duct entering into the nose through the inferior nasal meatus. That is that. The superior, one thing too, posterior ethmoidal sinus. So we have the anterior and the posterior ethmoidal sinus. So this image is not very big, but I don't think I'll be able to really show much with this. But your posterior ethmoidal sinuses are actually, can you guys see my cursor here? Can you see? Can
Yes.
you guys see exactly? So your posterior will be somewhere here, draining into the superior meatus. So all these things that you guys are seeing that are looking black, they are the spaces. So the spaces, the ones that are black, that's what's filled with air. So the ones that are black, that is coming down, that are black, those are your inferior meatus. So the one that is in the middle are your middle meatus. The one that is up is the superior meatus. All those black areas. In between, I'm not talking about the one that is outside, because there's another black one outside. You guys can see where they wrote Max. So that is your maxillary sinus. That's the sinus. That's the sinus, not a meatus.
How come the bilateral one is not like the other one?
So that one, there's accumulation of fluid there. That is why. That's infection. That's the sinusitis. You get. So there's accumulation of the debris, the mucus.
So the sinuses are usually empty. They're the empty, dark, like air-like stuff in the skull. So once you see any secretion or it's blood or something, that means there is something is collecting there.
Yeah, this is how it ceased to appear.
Yeah.
So, so this is how it will appear hyperdense like this. So hypodense rather. This is hypodense. This is hypodense. So it will appear hypodense. So this is like you have cyst here, you have cyst here, you have cyst in the orbit too. Your maxillary, your sinuses normally should contain hair. They should make the skull bones light. That's what they are there for. That should reduce the weight of the skull bone. They contain hair only. So, but once you can affect that drainage of the sinuses, because you can have some secretion and you can't have drainage again, the secretions keep accumulating within the sinus because they are continually being drained into the nose. So if they accumulate in the sinuses, you have those problems. So what do I want to say? So I said in the superior um um in the superior meatus, only one thing is drained into that area, the posterior ethmoidal sinus. We have two ethmoidal sinus. That is, the sinus are very close to the eye. The ethmoidal sinus, very in between the eyes and the nose. So the posterior and the anterior. The posterior is the only one that empties into the superior meatus. In the inferior meatus, it is only the nasolacrimal duct. But in the middle meatus, three things empty there. So we have the frontal sinus. The frontal sinus is what is up here. That one is up. That one is the one that is up. We have the what's it called? The maxillary sinus. Maxillary sinus is this arrow that they are showing. Maxillary sinus. Then we have the anterior ethmoidal sinus. Those are the three. The anterior ethmoidal sinus, the frontal sinus that is up, and the maxillary sinus emptying into the middle. You guys can already see the pathway for this middle one. This maxillary sinus. You can see this maxillary sinus. You can see that sorry that my cursor cannot be showing all these things. But you can see that there's like a track opening normally for it to be able to move into this area. So maybe there's an obstruction there. That's why it's kind of accumulated. Now, my point is, what do I want to say now? Yeah. So this maxillary sinus actually has, a disadvantage compared to the other ones because of its own position. It has a disadvantage because of its own position. What is the disadvantage? You guys can notice that it is located below the drainage. Look at the opening for the entry of the maxillary sinus. You guys can see that small opening in the middle meatus. Can you see something like looking at look at where my arrow is sitting now? Can you see that one?
Yeah.
Exactly. So fluid has to be moving from up, to go into that opening. It's different from the frontal accumulation that, in the frontal sinus, they are just located up. So that means that they can just track down with gravity. But the maxillary one has to move against gravity. So that is why you tend to have problem more with the maxillary sinus because they drain against gravity into the middle meatus. So you have to pay attention to that. So the maxillary sinus is the one that's having more problem because you have to move against gravity to drain into the middle meatus. So acute sinusitis is just when you have inflammation of the nasal cavity as well as the sinus within the nose. So the commonest cause is actually viruses. When you have viral infection of that area, it can cause rhinosinusitis. The person will just be having rhinorrhea, discharge, watery discharge, and all those things. Then it can get superimposed by some infection. So what are these bacterial infection? Non-typeable Haemophilus influenzae, strep pneumo, and Moraxella catarrhalis. So you can just use we've not started microbiology. So there are three microorganisms. I know that Dr. Oluwatobi will be very familiar with them. Three microorganisms that are encapsulated: the strep pneumo, the Haemophilus influenzae, and the Neisseria meningitis. Right, Dr. Oluwatobi? Hello?
She's giving you a thumbs up. I think she can't talk. Yeah.
Okay. So, but here you have to remove Neisseria because you can't be having Neisseria causing rhinosinusitis. So Neisseria is not the one here. It is Moraxella catarrhalis. Moraxella too is notorious for causing all these respiratory tract problems. So Moraxella
I think
catarrhalis.
Moraxella is like the commonest, like it's the one that causes normal flu, like regular cold and catarrh that people have. I think it's Moraxella, right?
No, it's rhino. Rhino is viral.
It's rhinovirus,
yeah, it's viral.
So the bacterial one is Moraxella.
So when it's superimposed,
okay,
Moraxella strep, pneumo, and
Okay,
hemophilus.
then H
So that's
info.
why we don't
So
give them
it's a
anything.
non-typeable.
Yes, the non-typeable hemophilus. Exactly.
Non-typeable.
Yeah,
Okay,
non-typeable.
okay.
Because you don't have vaccination against this one, so there's high chance of this one's causing the problem. So that. So the non-typeable Haemophilus influenzae, the strep pneumo, and the Moraxella catarrhalis. Now, the clinical correlate here is that all the sinus infection can spread to other regions because your sinuses are continuous with the brain, they are continuous with the cavernous sinus as well as the orbit. They are continuous directly with the orbit. You can see that the orbit is just beside them. You guys can appreciate that they are just beside them. So especially your ethmoidal sinus and the frontal sinus, they can spread directly to the orbit. So once they spread to the orbit, what do you guys think the person can develop? Anybody? I just want to try. Anybody?
Cellulitis,
Orbital cellulitis.
conjunctivitis.
Orbital cellulitis. Yes, it's orbital cellulitis majorly. So just see redness, swelling high, and all those things, discharging. Orbital cellulitis is one of those things that you are scared of. And because of the fact that what drains the orbit includes your facial vein and your ophthalmic vein. These veins drain into the cavernous sinus. So that means that you can have introduction of those infection from your sinuses getting to the cavernous sinus. And if it gets to the cavernous sinus, it's a problem because it basically drains majority of the structures in the eye and the head, your cavernous sinus. So that means that you have accumulation of those veins, those blood within those veins. So they will keep accumulating. They cannot drain. So if they cannot drain, there's especially those of the orbit. So that means that the eyes will be getting, because I've said it, your ophthalmic veins and your facial vein drains into cavernous sinus. If they cannot drain again, your eyes they'll become enlarged. Proptosis, periorbital edema. Then commonly you notice them having cranial nerve deficit because your cranial nerve 3, 6 especially they run beside it. So abducens nerve palsy, commonest. They can ask that question anywhere. Cavernous sinus thrombosis commonly affect which cranial nerve? Cranial nerve 6, you can never be wrong. Cranial nerve 6 is it. Although it can affect cranial nerve 3, can affect cranial nerve 4. They run by the side. Your internal carotid artery also passes beside it too. The anatomy is just very similar. Sorry, I don't have an image I would have shown us. But because of those contiguity, because they are very near to each other, they can be affected by this cavernous sinus, problem. So of course, everything is within the brain, so it can spread to the meninges of the brain. From the orbit, from the cavernous sinus, can get to the brain and affect the orbit, the meninges, and the person can present with meningitis. So one of the feared complications of sinusitis is meningitis. So you can have meningitis from sinusitis, you can develop cavernous sinus syndrome from sinusitis, you can have orbital cellulitis from cellulitis. So you guys should not forget, they are very close to the eye. They go to the orbit, orbital cellulitis. The orbit veins, drains into cavernous sinus syndrome. So proptosis, periorbital edema, headaches, um, and cranial nerve palsy, cranial nerve 6 palsy, abducens nerve palsy, then meningitis when it finally gets to the brain. Yeah, so let's talk about epistaxis. Epistaxis is just nosebleed. So we have one major plexus we have two major plexus, but we'll be talking about one. And the one we are talking about is Kesselbach plexus that is located within the nasal septum in the anterior aspect of the nose. So you guys can see it here. So it's a conglomeration of 5 arteries. So you guys can palm it this way. We have 2 palatine, the 2 that are named palatine. But I don't think they can test it actually, but it's good for you to know it. So you have the sphenopalatine, the greater palatine. All those palatine ones are actually coming from the maxillary artery. They are branches of the maxillary artery. Sphenopalatine, the um, greater palatine, we have mentioned 2 out of the 5 because of the fact that we just remember palatine. Now, let us remember ethmoidal from up. Ethmoidal, palate is from down. The palate here from down. Ethmoidal from up, ethmoid bone. Now, we have 2 ethmoidal, posterior and anterior ethmoidal, posterior and anterior ethmoidal, posterior and anterior ethmoidal. We are left with 1. That last one is your superior labial artery from your facial nerve, from your facial artery. Superior labial artery, just somewhere here from the lips. Superior labial artery. So the 5 of them, your posterior and anterior ethmoidal, your greater palatine and sphenopalatine and the superior labial artery, they come together and they form that anterior, the Kesselbach plexus. Now that Kesselbach plexus is very prone to injury. Someone that is just doing nose picking can, just dip his hand into the nose and traumatically, injure those vessels and cause bleeding. So by trauma, frequent nose picking or excessively dry nose. So when the nose is too dry, you are just putting your hand inside it and easily, foreign body can impact on that area and cause tear to those arteries. So someone that have allergic rhinitis, the inflammatory process can also affect it. Then nasal angiofibromas, especially in adult males, in adolescent males, they can have nasal angiofibromas. So fibromas, so there are benign tumors affecting the connective tissue within the blood vessel. So like the muscle, like maybe the tunica media adventitia or something, you can develop malignancy. So your connective tissue, which is the muscular part of the vessel, can have tumors that we call angiofibroma that can also bring about that bleeding. So bleeding can happen in the anterior segment when there's damage to the Kesselbach pressure from any of these things: foreign body trauma, allergic rhinitis, excessive inflammation, and that. Then nasal angiofibroma, and you can also have damage to the posterior segment. So there are some vessels in the posterior segment. That's another name. But the major thing about that posterior segment is that the major artery that is damaged there is the sphenopalatine artery, just like what we are seeing in this image. The sphenopalatine artery is the most posterior of the artery. So what I just want you guys to pay attention to here is that although the commonest form of the bleeding occurs when there's trauma to the Kesselbach plexus anteriorly, but when you have damage to the sphenopalatine artery posteriorly, it is very, very severe and life-threatening because of the fact that it's very difficult for you to establish nasal packing to that area compared to if you have an anterior bleed, so that you can quickly arrest it, and again you are bleeding directly to so they can have nasal occlusion and all those things from that bleeding. So you don't want a posterior segment bleeding to happen because of the difficulty in securing hemostasis in that area. So, and the posterior segment bleeding is actually due to a damage to the sphenopalatine artery. Yeah, so are we clear on epistasis?
Yeah.
Okay. So,
Yes.
all right. So head and neck cancer, like we have talked about some days back, head and neck cancer, majority of time is squamous cell carcinoma. And there are some carcinogens that are native to the word squamous cell. Once you hear squamous cell, you're always thinking about, is this person smoking? Is he taking alcohol? Or is he having HPV? Those guys, you can never go wrong. Once you see squamous cell, one of them have to be implicated, and they usually go together. So, alcohol, they are irritants. Tobacco, HPV 16 and 18, but 16 majorly, they can cause, oropharyngeal cancers, squamous cell type. Your HBV can cause nasopharyngeal carcinoma. So you guys pay attention. We are talking about alcohol and tobacco can actually cause both nasopharyngeal and oropharyngeal. But HBV is strictly oropharyngeal because all of them are both head and neck. Oropharynx, nasopharynx, they are part of the head and the neck. But the nasopharyngeal carcinoma is caused by HPV, Epstein-Barr virus, not HPV. EBV causes nasopharyngeal. HPV 16 causes oropharyngeal. Tobacco and alcohol can cause both. They can cause both. So there's also something called field cancerization. So once because head and neck is a large space. So once you have exposure of the head and neck to a carcinogen, maybe tobacco, alcohol, you notice that different cells within that region is going to be undergoing genetic mutation independently, and they will be developing that tumor independently of one another. That is, what we are saying is that it's not actually due to metastasis. It's not tumor A that is spreading to the next area. No, tumor B is developing independent of tumor C because of the fact that all of them have been exposed entirely to that carcinogen at the same time over a long period of time. So they develop. So we have to pay attention to the word field cancerization. It happens commonly in the head and neck. It can happen in other areas too, but it happens usually in the head and neck. And when they ask the question, they usually ask it pertaining to head and neck malignancy. So what about nasopharyngeal carcinoma? Okay, how can they present? Because that means you have a carcinoma, you have a mass within the nasopharynx. And nasopharynx is like a part of your pharynx because you have a pharynx divided into your, oropharynx and your nasopharynx. Before it now opens into the larynx and now, goes to the trachea, then also separates posteriorly into the esophagus. Now, the nasopharynx is just, the part behind the nose, not the part of the pharynx behind the mouth. The part of the pharynx behind the nose. That is our nasopharynx. So I'm trying to look at this image so that we can palm it. So this is a nasopharynx now. It's just superior to our pharynx. Yeah. So we can see from this region now. This is our nasopharynx. Here is our nasopharynx. So how will they present? You have a mass there. It's usually unilateral. It's not that big. You just have that carcinoma obstructing one part of the nose. So they have a unilateral nasal obstruction. They have difficulty in breathing. They are having nasal discharge, and of course they can have epistaxis when there's injury to the vessels that are around that region, which includes our posterior splanchnitis artery and the other arteries that are just very posterior. Because of the fact that the nasopharynx is connected to the middle ear by the Eustachian tube, we can have some additional complication. So, if someone has a nasopharyngeal carcinoma, there's tendency of the tumor growing into the Eustachian tube that connects it with the middle ear and can cause the blockage of the Eustachian tube. Now, usually you have mucus, cerumen, earwax, cerumen, and mucus being secreted within the middle ear cavity so that I can constantly clean it. At the end of the day, you cannot have clearance of those, middle ear secretion. Now, they start accumulating and they can be a needles for infection. So you can develop otitis media from there, with or without effusion, depending if it's now secondarily, complicated by, infection and the infection starts spreading and they develop effusion at the end of the day. And of course, it's going to cause air loss because your middle ear cavity cannot transmit sound again, into your inner ear because of the occlusion. So that is the way nasopharyngeal carcinoma can present. So it can actually present more than this, but this is enough. Once you see them painting scenario of someone that's having difficulty breathing, obstruction, some of them can even have difficulty in speaking, swallowing rather. They have difficulty in swallowing, they can have nasal discharge, they can have occasional nose bleeding. Then if you get complicated with obstruction of the middle ear cavity, they can have otitis media and also hearing loss from the effusion from the debris occluding the middle ear. You have hearing because of the fact that the Eustachian tube has already been blocked. So there's no way you can have drainage of materials from the middle ear into the nasopharynx so that you can take it out. So that's that about nasopharyngeal carcinoma. So another tumor that we also need to know about the head and neck is laryngeal papillomatosis. Okay, and I talked about this last time that it's very high yield. We need to remember it. It's also called recurrent respiratory papillomatosis. Forget about the big name. They're just talking about papilloma, benign tumor occurring within the vocal cord. That's just what they are saying. We have tumors occurring within the vocal cord, and these tumors are actually stratified squamous cancer. So they are affecting the stratified squamous epithelium lining the vocal cord. I think I've seen a question on them asking about the epithelial lining of the vocal cord. So stratified squamous epithelium. We should pay attention to that. So it's a benign laryngeal carcinoma. You know that the vocal cords are part of the larynx. So that's just the opening of the voice box, the vocal cord. Yeah. So the larynx of the larynx is just like opening, and it's being bordered by the vocal cord. Yeah. So you can have a cancer within that vocal cord and they arise within the squamous epithelium, and it's being caused by two major organisms, human papillomavirus 6 and 11. So you can see any one of them. You can't see both 6 and 11. So you just notice that the person will be presented with difficulty in breathing because your larynx, leads to the airway. So hoarseness of voice, difficulty in speaking, difficulty in breathing. That's a typical way that they present, especially in children. There's an adult form, but I think USMLE is actually more interested in the children form. So just a young child having problems with speaking, with breathing, and the biopsy, they see, tumors resembling sapphire squamous epithelial cells. And they are warty like, finger like projection. That's your laryngeal papillomatosis, implicating autism, HPV 6 and 11. Okay, so let's start talking about the interesting part. DVT. I know that we know this one very well. DVT just means deep venous thrombosis. You have a clot within the deep vein of the leg. They commonly arise from the deep vein of the leg, but its location, um, 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 they vary based on the location. Some happen at the lower part of the deep vein. Some happen at the proximal part. Majority arise from the proximal part of the deep vein. So we are talking about the common iliac, the femoral, and the popliteal vein. That's what we are saying. The iliac, the femoral, and the popliteal vein. Those are the proximal part of the veins draining the lower. We are not talking about the posterior tibial or the other ones. So we are saying the popliteal in the posterior to the ankle, the femoral, and the iliac. So that's where they usually arise from. So if you have someone has a DVT in the leg, you are going to see the cardinal signs of inflammation. So warmth, pain, redness is usually common. Warmth, pain, redness. What are the causes? The virtual triad: stasis, hypercoagulability, and endothelial damage. So stasis. So someone that has been in the hospital for a long time due to surgery, someone that has been on a flight for a long time, someone that has been a long time truck driver. So that's the typical way that they like describing it. Say truck driver that drives for a long time, you already know that they are trying to paint your mind towards DVT. Or someone that done surgery, post-op that is now recovering. Person might not be able to move for a while. So they can be predisposed to developing DVT because of the stasis. Hypercoagulability. So what can cause hypercoagulability? Pregnancy. We already know, we've said it when we were talking about our reproductive lecture, like people that are pregnant, they have high expression of those coagulation factors so that it can help them reduce bleeding when they are delivering. People that are on OCPs, people that are using oral contraceptives, so they are using oral contraceptives because of the estrogen component. Estrogen triggers thrombosis, so they can have clots. Factor 5 leading, there's problem with the protein C and S, protein C specifically inhibiting factor 5. So factor 5 continues triggering the activation, the coagulation cascade, and there's clot formation. So factor 5 leading mutation, people with OCPs and someone that is pregnant, they are predisposed to having DVT due to hypercoagulability state. Endothelial damage. So once you are damaged the endothelial from anything, trauma and all those things can expose collagen. So when collagen is exposed, vulnerable factor is able to activate, and then you have the coagulation cascade firing. So all those three things can be a porter for DVT. So one of the feared complications of DVT is pulmonary embolism. But before we get to the complication, let's talk about the test. So if you want to do a laboratory test for DVT, D-dimer is one. But please, if we tell you what's the best test, although that's not step 2, you guys are doing step 1. So, but D-dimer is not actually the best test. Your D-dimer can just help you to rule out because it's highly sensitive, but it's not specific. Why? Because there are so many things that can cause elevation of D-dimer that is not actually causing DVT. So, for example, someone can be pregnant and the person who doesn't have DVT and can have elevated D-dimer. Someone can have a malignancy, D-dimer will be elevated. Someone that has done surgery. So D-dimer is just a product of breakdown of fibrin. So when you have fibrin degradation, one of the products is D-dimer. So you just test it. So someone that has some malignancy, someone that has some autoimmune disease like rheumatoid arthritis, someone that has undergone surgery, trauma, malignancy, they can all cause elevated But it's very sensitive. It's very sensitive, but it's not specific. You cannot say that, oh, it is actually DVT that is, causing this elevated D dimer. But the imaging test of
Dr.
choice,
Babawale, sorry.
yeah,
What you are saying, so isn't it rather sensitive?
no,
Oh no, so meaning that if D dimer if D dimer is not elevated, you can say that it is not DVT.
yes,
Yes, you
very
can.
So
true.
it's highly specific rather, right?
No, it's highly sensitive. What
It's
you said,
sensitive. It
what
can
you said
detect.
now is in favor of sensitivity. So, because if someone has D dimer, look at what you said. You said if it's not
Dr.
Mm-hmm.
elevated.
Wawade, Dr.
If
Wawade,
it's sorry,
Sorry, Dr.
I thought.
Lushola. I will attend to you. Sorry, Dr.
no,
Lushola.
Okay.
sorry, sorry, yeah, just a minute. I'm
So,
listening, Dr. Babawale.
if you say that D-dimer is not positive, that means that you can
Mm-hmm.
confidently say that the person doesn't have a DVT. That means you are saying the test is
Yes.
highly sensitive. Because if the person has a D-dimer, you are going to see if the person has a DVT, you are going to see the D-dimer. That's sensitivity. If I have it, I'm going to see it. That means I'm sensitive. I can detect it. Do you get
Okay.
it? So
Okay. Okay. All right.
specificity is talking about it is only that condition that you can see that thing. So it's not specific because there are so many things that can cause D-dimer to be elevated.
Okay.
So that is it. Yeah.
I guess it. Thank you.
Yeah. So Dr. Lushola.
It's about this sensitivity issue. I was thinking that D-dimer was supposed to be specific to, like Dr. Francois said,
No.
since it doesn't state that the person has the disease.
No. Like that's why we said is low specificity because it doesn't state that it is strictly DVT. It can be any other thing. So specificity means that you are saying that it is only that thing that can cause it. Let's say that it is only yeah. So we can say that bite cells, finding of bite cells on our blood smear is specific for GCPD deficiency. Yes, it has high specificity because it is only GCPD deficiency that can cause bite cells to be present. But if sickle cell anemia can also cause bite cells, I would not say that test is specific.
Maybe we should not prolong it. The way it's ringing in my head is like, for example, if I see D-dimer, should I think that this person has the disease? If I say D-dimer and this person has the disease, that means I will say it is sensitive. That's
Okay,
what is
I
ringing in
get
my head.
I get the confusion. This is it. If you do the test and it is present, you can say that the person you can have a belief that the person has DVT, but you cannot categorically say it that it is DVT that is causing that thing. Do you get it? See, sensitivity is you being able to detect something when it is there. That is
Okay,
sensitivity.
okay,
You
okay,
being able to
okay,
detect it when
okay.
it is there. So, because now let me give you example of what can cause poor sensitivity. Now, if normally, um, let me use okay, let me use I'm trying to look at something that is real. I don't want to fabricate anything so that you guys can understand. Um, uh, okay. Let me use LVH and hypertension. You know that hypertension can cause LVH. You know that.
Mm-hmm.
But it is not in everybody that is hypertensive that you see LVH. You know. It depends on the stage.
Mm-hmm.
Yes. So that means that we can actually use LVH to test hypertension. But it's not sensitive.
Okay.
It's not sensitive because you can test for LVH. You can bring someone that's hypertensive now and you test for you do echo to check for LVH and you not find it. And whereas the person is hypertensive, that means that LVH to detect hypertension is not sensitive. But
Okay.
D-dimer is sensitive for DVT because once you have DVT, you have D-dimer. That one is constant. It is constant stuff. But it's just that it's not specific because there are so many other things that can cause that D-dimer to be elevated aside DVT. So that means that you might
Okay.
also want to do other tests to corroborate your diagnosis of DVT after finding your. So that is why if you look at abroad setting, when they want to make diagnosis of heart failure, one of the things that they do is what? They do BMP. BMP measurement is very sensitive to detect heart failure, but it's not specific. It has a very low negative predictive value because it is not only heart failure that can cause BMP to be elevated. If I have anything that can cause volume overload, my BMP level will be high. If I have a Conn syndrome, I have Cushing syndrome, I have anything that is making my blood volume high and the amount of tension in my heart muscle is increasing, they will secrete BMP. So it is only sensitive. To now specify that, okay, I've done BMP, it's positive. Let me now, that means it's very sensitive. Now, okay. And I want to be sure that this thing is heart failure because I know that BMP is low specific. I want to be sure that it's heart failure. What do I do? Let me listen to the heart sound. S3. Okay, gallop reading. Orthopnea. Oh, this is heart failure. This is not Cushing syndrome. This is heart failure. You can see. So that means that S3 and my orthopnea, paroxysmal nocturnal dizziness are specific for heart failure, but they are not specific for Cushing disease. But because of that, Cushing disease can also increase blood volume. They can increase delivery to the atria that can stretch it. Both of them will cause increased production of BMP. So BMP is highly sensitive for them, but it's not specific for the heart failure, and it's not specific for the Cushing syndrome. So, that's the way it's a very confusing, but once you get it, okay. So the imaging test. So once you have done your D-dimer and your D-dimer is elevated, okay, you can be suspecting DVT. You can be suspecting DVT once D-dimer is elevated. How can you now nail it specifically that this is DVT? Do your compression ultrasound. Your compression ultrasound will only be positive for someone that has a DVT. That's why it's highly specific for DVT. So do your compression ultrasound of that. So you put your ultrasound there on that, there you see the clot there. You know that, okay, this is actually DVT that I'm dealing with. So what do you want to do for that person? You want to give unfractionated heparin or low molecular weight heparin. You want to give heparin because they act immediately. Heparin is given subcute or subcute. It acts immediately. It acts immediately. So you can use it for an acute management or you can use it for prophylaxis. You want to prevent it from happening. Someone has a high risk factor. We'll still talk about well score maybe later. Well, it's not now. Maybe I think that's step 2. So you can use it to predict someone that is going to have a DVT or not. So if you find out that, okay, this guy has high chance of having a DVT, you want to give the person prophylaxis by giving your unfractionated heparin or low molecular weight heparin. So if this person has a kidney problem, which one are you going to give, Dr. Francois? These are
Unfractionated heparin.
unfractionated. Fantastic. So, if you want to, for long-term prevention, you might want to keep the person on, the direct anticoagulant, rivaroxaban and apixaban. Those ones you don't need constant monitoring. You don't need it. Abi, Dr. Francois, do we need constant monitoring for our DOACs or DOXA?
No, we don't.
We don't need it. We don't
No,
need it.
they're stable. Yeah.
Stable. Exactly. But if you have a very severe form of PE or a very severe form of I said PE, very severe form of DVT, you might want to give thrombolysis, but you don't use thrombolysis. So don't pick thrombolysis in your answer. If you see treatment, go for one of the anticoagulants. It is anticoagulation is a mainstay. Don't say that I want to go and break the clot. You don't go after and break the clot for DVT unless it's very big. Unless it's very big. So, all right. So P is one of the complications. Sudden onset difficulty in breathing, sudden onset tachycardia, P. Sudden onset difficulty in moving hands, sudden onset weakness in one part, stroke. So sudden onset, very important for PE. Once you just have that clot dislodging, going to the IVC, entering the right atrium, the right ventricle to the pulmonary circulation, they will stay there. They will stay there. And they can get occluded and cause pulmonary embolism. How will they present? How will they present? So pulmonary embolism is strictly obstruction of the pulmonary artery, or it branches by a foreign material. Now that foreign material can be anything. It can be anything. So, but here we are looking at the thrombus. that is coming from a DVT. So from a leg, it's embolizing to the PE. Now, what will happen? There will be an obstruction at that pulmonary artery. That means that blood cannot flow to the pulmonary capillary, cannot go to the pulmonary vein. You guys note what he said here. Affected alveoli are ventilated but not perfused, causing a VQ mismatch. You guys are seeing that they are not talking about the VQ mismatch for the AA gradient here. This is what we actually started. Do you guys get? It will not be perfused initially. Hello? Are you guys still with me?
Yes.
Sure.
Yeah, we can hear you.
It will not be perfused initially, then it will go back through the other opened capillary. So, that's where you now have mixing of those deoxygenated blood that is causing that VQ mismatch. But you can also have the VQ mismatch. The VQ mismatch you are talking about here is just that the Q is dropping with respect to the V. So how will they present? They have a sudden onset dyspnea. That sudden onset is very important. Sudden onset dyspnea, they have chest pain, which is worsened by taking a deep breath, or when they are inspiring, they experience that chest pain. That's pleuritic chest pain, and they have tachycardia, tachypnea. Those two things, they are classic, very important in PE. Tachypnea, tachycardia. Then they're hypoxemic, and they have respiratory alkalosis from the hyperventilation. They have tachypnea, they are going to hyperventilate, but they will try to hyperventilate to take out CO2 and take in oxygen because of the hypoxemia. But the oxygen is not going to enter because there's no way to enter. Everywhere has been blocked. So at the end of the day, they will still remain hypoxemic. But it depends on the stage. This hypoxemia is not a constant feature. But the other ones you have here, sudden onset dyspnea, tachypnea, they are always there. But hypoxemia might not be there. So don't say that because you didn't see hypoxemia that you're not. No, so it might be there, it might not be there. But they will always have a respiratory alkalosis due to the hyperventilation from the VQ mismatch that they experience. Yeah. So there's something called saddle embolus. That's where you have the emboli, staying within the embolus, rather staying within the pulmonary trunk, where it is bifurcating into the right and left pulmonary artery. If there's a clot at that region, it can cause sudden death, because at that point you have complete failure of blood flowing into the right and the left pulmonary artery. Because if you have it at one of the branches of the pulmonary artery, okay, blood can still go to the other areas of the lung. But when you're having at the pulmonary trunk, that's a junction where it's bifurcating, it doesn't go to any of them. It can cause sudden death because you have right-sided heart failure immediately, and the person becomes hypotensive, and it leads to cardiogenic shock, obstructive shock, not cardiogenic. Hope you guys know that it's not cardiogenic and it is obstructive. So it's not cardiogenic shock, obstructive shock. I was about making that mistake. So there's an obstruction to the blood flow. So it's obstructive shock. Yeah. So because of the fact that you don't have blood leaving the right ventricle to the left ventricle to perfuse the systemic circulation. So it's very, very lethal. They can die. So what is the imaging of choice that you want to use to diagnose your PE? You want to use your CT pulmonary angiography. So you want to do angiography, to check through the vessel of your pulmonary vasculature. Of course, you are going to see filling defects. So I think we have an image here that shows it. So this is a PE. This image is very high, guys. You can see something like this in your exam. So,
Idarosizumab.
Idarosizumab, yeah, Idarosizumab. What about
Bad.
Abilifadine.
the
Yeah.
factor 10?
10. Rivaroxaban.
Rivaroxaban?
Sorry.
Apixaban, yeah.
Apixaban.
Edoxaban is part now.
Sorry.
Which one?
Edoxaban.
Those ones are rare.
Right.
Like they are not, you get.
Those are low molecular weight heparin.
It's okay.
Edoxaban. Apixaban, Rivaroxaban. Those are our factor 10A inhibitors. Enoxaparin, Sorry, is it enoxaparin that I said or apixaban?
Enoxaparin.
No, low
Enoxaparin is
molecular
low
weight.
molecular weight heparin.
Sorry, what did I say earlier? Is it not?
I don't even know the drug you mentioned. Me, I only know two
I
two
Exactly.
said
main
Now why I
adoxaban.
inhibitors.
say, now
Said
why I say, what is
adoxaban.
he saying?
I
I don't know. I don't even know what he was
Me, I
talking
know only
about.
two. I know rivaroxaban and
So
have
me,
apixaban. Those
I
are
already,
the
just
two
kept
I know.
quiet.
I have
You
already
I
get?
know, right?
confabulating. I have already confabulating. Oh my god!
I mean,
This
I'm like, what's the
this is
Baba Wale saying again?
pseudo Kodak pumping. Okay, so that's the treatment. You want to give heparin or your DOACs, the thrombin and the factor 10A inhibitors. If you cannot anticoagulate, maybe this person has gone for surgery, you cannot anticoagulate that person, or the person has malignancy, or the person has low platelet count or something that can, you don't want to anticoagulate that person. You want to give IVC filter. So you just place that filter within the IVC. It's going to trap any clots that is coming from the legs, prevent them from actually forming PE. So you actually give your anticoagulation, to treat and also to prevent your PE. Then another modality is to use IVC only if anticoagulation fails or anticoagulation cannot be done. That's when you put your IVC filter. So it's one of those things that they do in interventional cardiology. For some of us that wants to, like Dr. Bisola, that she's thinking of
Sir?
internal medicine,
I am
MTOC
cardiologist now.
is one of
Yeah.
okay, Dr. Zulia, you also MTOC. Yeah. So it's one of those things that we do, aside PCI and coronary arterial bypass grafting, they also insert IVC. We don't do it here I think they do it in only Unilag or something, Lutz or something. That's where they do it. So
Dr.
it's so very,
Babale, what's the source of your information?
I have friends that are there that,
Eh,
witness.
why you now sure it's only loot? Let's
Ah,
continue our class.
it's only,
Continue.
wait, Dr. Abisola, have you said they do
Yeah.
Say you said they do no, correct me now.
Don't underrate us. So
Where's your center?
no worry. I'll see you later.
Okay, no wahala, no wahala, no wahala. Make I come train. Make I come train for that place. Yeah, so what are the type of things that you can find within an embolus? Can be fat, can be hair, can be thrombus itself, bacterial, like someone that has a septic, someone that has infective endocarditis, bacterial, septic emboli, bacterial, amniotic fluid, someone that have given birth, or a tumor. So let's take them one by one. So the fat, the air, the amniotic fluid, they can actually cause some syndromes in which pulmonary manifestation are part of them. They can cause some symptoms in which pulmonary manifestation are part of them. So what we are talking about for PE is strictly thrombus. So what if it's fat? What if it's air that's embolizing, bacteria? How will they present? So we are looking at fat emboli. This fat emboli is three things that you see: respiratory manifestation, neurologic manifestation, and the skin manifestation. Now, how you're able to get this is because once fat embolizes, so the way they will picture it, they will just tell us that someone had a long bone fracture, or the person went for liposuction, or something that had injured the long bone, maybe a surgery or something, because of the
I've
fact that
seen
long
this
bone,
before.
huh? The what?
I said I've seen this before.
Yeah, it's a very, very, you see, this kind of question is only
Vegetarians.
people that are stuffy that can get this question. Once you are asking somebody, tell me the child of fat temple, and he's saying it, that person is already on another level. Many people don't pay attention to this kind of thing, and it's important. They ask it a lot. I've seen it many times. Hypoxial, neurologic abnormality, and so I want us to always be saying this thing. I'll be asking us. We must remember it. So if someone has a problem with the long bone and there's a fracture, because of the fact that they contain, the bone marrow, and fat is also part of the bone marrow, the fat can dislodge, it can enter into the venous blood, and from there it can travel to the lungs, RV, to the RA, to the right ventricle, to the pulmonary circulation. But the fat can escape the pulmonary circulation and go to the left to find its way to the systemic circulation. So it can find its way to the brain and cause neurologic abnormality. Fats can also trap within the dermal capillaries. So when it traps within the dermal capillaries, it will cause extravasation of red blood cell into the skin. That's what is responsible for the petechial rash. But this rash is not usually sustained. It goes away after like 2-3 days. But of course, when it gets to the lung, it's going to cause ventilation perfusion mismatch that brings about hypoxemia. So they will have dyspnea, sudden onset dyspnea, neurologic abnormalities. Maybe they cannot move one hand or they are just having seizures. And of course, petechial rash from extravasation of red blood cells. So once you see hypoxemia, neurologic abnormalities, because it can get to the brain, and petechial rash due to affectation of the dermal capillary, you are dealing with fat emboli. Fat emboli. What you give this person is only oxygen. That's what they need. Oxygen can help, or one of the first line to treat them is give oxygen. Okay. Then hair embolism. Hair embolism usually occur, in people that are scuba divers, that people that are diving deep inside the sea, and they are suddenly coming out. Do you guys remember when we were talking about the atmospheric pressure? So the higher someone goes up, what did we say happens to the barometric atmospheric pressure? Who remembers? Anybody?
The
It
lower the
reduces.
pressure.
It decreases.
Reduces.
It reduces. Now, what happens when someone goes down into the sea?
It should increase then.
It will increase.
Increases.
It will increase, right? It will increase. So that means that what will happen to the amount of oxygen or gases that are within the blood? What do you think will happen to them? Will they increase or they will decrease? The gases in the blood. I just want you guys to just say anything. From what we have been discussing, what do you think will happen when the pressure
At which point? When the person goes down
At
or
which
when the
point
person goes down?
exactly?
When the person goes
PaO2 will
down,
increase.
they are what?
To
should
increase.
It will
reduce.
No, I'm hearing different things. What are we saying?
Reduce.
No,
I think it's
Yeah, I
increased.
thought PaO2 will increase now
it
with
will
that.
increase. It's not only PO2, everything. There's
Partial
what we
pressure of
call
oxygen.
Everything should increase.
this Charles law. So, once you have increased pressure of a gas, it will increase the solubility within a liquid due to the increased pressure of the gas. So that's it. So that means that as you are increasing that pressure as you are going down, the solubility of those gases within the blood increases. So they will stay in the blood. That's why you see that the problem is actually when they ascend. So when they ascend, that means they are suddenly decompressing. They are moving to an area of low pressure. Normally, you are supposed to have escape. You are supposed to have those gas moving out into the atmosphere. But if they have um maybe an obstruction or something, it can prevent those gas from escaping. Maybe there's a mucus plug somewhere, or maybe there's just air trapping from anything that is preventing those gas to escape. Then they can have precipitation of those gas finding their way into the blood vessel because of the sudden decompression that they have. Because it's not everybody that sudden decompress that can have that condition. But if you have sudden decompression and you have problem with the gases finding their way outside, then that is where problem start. So the majorly implicated gas is actually nitrogen bubble. So they can precipitate out of that solution, because they are already dissolved in solid, in liquid rather. So as they are now ascending, they are precipitating out of as gas to escape out of the atmosphere. So if they are not able to find their way out, they go, into the blood vessel and they can cause an emboli. So another way by which you can have hair, occluding vessels is when someone wants to do a central line placement. So if you want to insert a central line, because the point at which they insert that central line is actually very close to where you have the emptying of the veins into maybe the jugular into the SVC. So that area has a very low central venous pressure. It's relatively low central venous pressure compared to the atmosphere. So there's tendency of air moving from the atmosphere into that area, causing the emboli within the central venous region. So what you want to do is that before you want to place your central line, is either you want to place the patient on maybe a Trendelenburg position, a little bit head down, so that you can increase pressure to the central venous region, or you give the person enough fluid so that it can increase the central venous pressure. Because if you increase the preload, you are increasing the central venous pressure so that you can prevent gas from moving from the atmosphere into the other precautionary measures, We are not CTSU guys, so we shall know that central line placement and sudden decompression can cause here emboli. Then the last one is amniotic fluid emboli. How does it occur? Labor or just immediately after delivery. So what happens? I don't think, okay, I think we need to know about the spectrum. So what happens is when you have amniotic fluid emboli, because the amniotic fluid can actually, and the fetal tissues can trigger the coagulation cascade, particularly through the extrinsic mechanism. So you have clot formation. The clot can include so many of the areas like the pulmonary vasculature, increase the pulmonary vascular resistance. They can have a right heart failure. It can also include the myocardial capillaries. When it includes the myocardial capillaries, they can have a left cardiac failure and a cardiogenic shock. So all those ones, so can explain some of the features that they present with, like hypoxemia, reduced oxygen saturation, respiratory failure. And of course, like I've said, the amniotic fluid is, so that's the first phase. Then the second phase is now, when there is now consumptive coagulopathy. So those coagulation cascade becomes, too much, and the coagulation factors become consumed. So at the end of the day, bleeding starts setting in. So DIC can be the picture later on. So the first phase of this amniotic fluid emboli is, okay, the clot is happening. It is occluding all those vessels that we have talked about, the pulmonary vasculature, hypoxemia, respiratory failure, right-sided heart failure. It's also causing problems within the myocardial capillaries that supplying the heart muscle, particularly that of the left ventricle, causing heart failure like a cardiogenic shock, because the left ventricle cannot contract to bring out blood. Then um which one are we talking about again? Yeah, so that is that. Then of course with time, those coagulation cascade become excessive, and you have consumption of plated at the end of the day. Then DIC starts happening, and what happens in DIC is, as you're having clotting, you're having consumption of your clotting factor, and it will lead to bleeding. So at the end of the day, the second phase is actually with bleeding, uncontrolled bleeding. Just puncture a site, it's bleeding. You puncture anywhere, it's bleeding uncontrollably. So that is DIC, which can complicate amniotic fluid emboli. So it is very rare, but it's actually with high mortality. There's a high chance that person is going to die. So you should pay attention to all those features. So someone that sudden onset difficulty in breathing due to sea diving, that is air emboli. Someone that said difficulty in breathing with rash, neurologic problem due to accident, fat emboli. Difficulty in breathing, with bleeding from all the orifices, desaturation, hypoxemia, respiratory failure after delivery, amniotic fluid emboli. Okay, I don't know, maybe we should just stop at mediastinal pathology, or just, guys, let us stop here. We'll continue from here tomorrow.